Hello friends. So today I'll be talking on this VExUS score. So I'm sure many of you would have been hearing about this. So it's a sort of a new concept in ultrasound. So I have to acknowledge two of my colleagues. So Dr. Pratibha, who helped me develop this content, and Dr. Hrishikesh Jha. He's from Ranchi. So in fact, he's very passionate about ultrasound, and I think he has been doing a lot of work in VExUS. It was him who sensitized me to this whole concept of VExUS by sharing very good images. So some of the images that I may be showing here, thanks to Hrishikesh, who has happily shared with these images, mainly the Doppler images. So he's very passionate, and he's been doing good work in this VExUS, and I hear he's doing some studies as well. So thank Hishkesh for providing me with his images. So, so what do we understand by this concept VExUS? So it is an acronym which is venous excess ultrasound score. That's what it is. So basically, the whole concept is trying to look at the venous congestion as an indicator of organ dysfunction. So that is the whole concept behind the VExUS score. So why we have moved to VExUS score as a tool in addition to already available parameters. So right now, uh, the way we assess the fluid responsiveness is to a large extent with echo, we use IVC collapsibility sort of a variables. So we look at IVC diameter, and we understand in rough sense, when you have an IVC diameter less than 1, then the volume status is low. If it is more than 2 centimeters, we understand that they are euvolemic. This is in a rough arbitrary sense. Obviously, we look at dynamic indices. So in someone who is intubated and mechanically ventilated, we look at IVC variability, which is maximum IVC diameter minus minimum IVC diameter divided by mean. If it is more than 12% in intubated mechanical ventilated, we consider it as fluid responsive. Or in intubated mechanically ventilated, we look at IVC distensibility index, which is maximum diameter minus minimum diameter divided by minimum diameter. More than 18% is taken as someone who is fluid responsive. In spontaneously breathing, we take collapsibility index, which is maximum minus minimum divided by maximum. More than 40% is suggestive that possibly patient is volume responsive. Then there is right internal jugular vein distensibility index. Diagnostic accuracy is much lower than the IVC. So this is our understanding currently in intensive care about the volume status. So now where is the question of the VExUS? So the some of the pitfalls of IVC diameter is so one could argue that in spontaneously breathing patient, it may not be very sensitive in assessing the fluid responsiveness. And IVC diameter, if it is more than 2 centimeters, it sort of reflects on venous congestion. So there is more of venous congestion within the organ. So this is what led to the origin of concept of venous excess ultrasound, which is a 4-step protocol. So in these 4 steps, we look at predominantly, we start off by doing IVC, and which is a reflection of venous congestion at the cardiopulmonary level. Then we look at venous congestion in the liver. So we look at we look at the portal vein and hepatic vein, and we do certain indices to look whether there is congestion of the veins within the liver. And the fourth one we look. So one is the IVC, which is reflective of hepatopulmonary. Then we look at hepatic vein and portal vein in the liver, which constitutes 2 steps. And the fourth step is looking at the venous congestion within the kidney. So we look at the intra-renal veins and look at the Doppler and look at the venous congestion. So this is the sort of the sort of variables that we take, and we derive a certain score, and which we call it as a VExUS score. So how to perform a VExUS exam? So like any other ultrasound, patient has to be lying down comfortably, and it is preferable for any venous study. In fact, I tell my trainees, sometimes you may not be able to visualize IVC very much, but a simple maneuver by bending the legs and asking them to take a deep breath will open up a lot of veins. So for VExUS, because you are looking at a smaller veins, predominantly within the liver and the renal veins, it is desirable that patient is lying flat with the legs bent so that the veins tend to open up and if feasible in a deep inspiration. So step 1 is to look at IVC, which all of you are, I'm sure most of the ICU listeners who are listening to this are experts now in IVC. So you put at the subsyphisoid, maybe 1 centimeter, 2 centimeter lateral to the syphisternum, and you will get a IVC which looks like this, and you take a diameter. So that is the first step in VExUS. So if IVC diameter is less than 2 centimeters, then you know there is possibly no venous congestion. VExUS score is 0. So you don't need to proceed further. So this whole concept of VExUS will only arise when the IVC diameter is more than 2 centimeters. Then you need to go on to look at venous congestion in the liver and venous congestion in the kidney. And then you have to score whether they score from 1 to 3, whatever the score may be. So your whole VExUS principle starts only when the IVC goes more than 2 centimeters. So when you look at IVC, there are 3 veins that branch out from the IVC, which look like branching out from the IVC, which are the hepatic veins. So you have a right hepatic vein, you have a middle hepatic vein, and then you have a left hepatic vein. So this is how the hepatic vein looks. So as you see this, you have an IVC, you have an aorta, and then you have these hepatic veins, which sort of tends to branch out from that. It looks as branching out from the IVC. So for looking at the hepatic vein, you need to use the ultrasound probe with the patient lying down flat with flexion at the hip joint, preferably, and at the syphisternum, like IVC, and maybe you have to maneuver it few centimeters lateral to the syphisternum, and then you would see hepatic veins looking like this, which is called bunny sign. So you have a left hepatic vein, then you have a right hepatic vein, and you have a middle hepatic. It looks like a rabbit, so that's what we call as bunny sign. And once you see that, you place a Doppler. You place the cursor and put the Doppler to assess the waveform. So this is again a courtesy image by Rishikesh, where he has sent me this nice video where you can see this bunny video. So you can see that is how the left hepatic vein, the middle hepatic vein, and the right hepatic vein looks. And then he has put in other videos. We'll discuss about it in the subsequent. So this is how the bunny sign looks. So you place the cursor, insonate it, and you put a pulse wave Doppler. So normally in hepatic vein, this is how you see the waveform. So I just put it in a schematic way to make it easy. The systolic wave will be bigger than the diastolic wave. That is the normal. So S is more than D in the normal. And in the Doppler, when you put the actual image looks like this. So S is bigger than Doppler. I'll show certain Dopplers which Rishikesh has sent me. So if there is a mild hepatic impairment, when I say mild hepatic, when there is hepatic congestion, so the systolic becomes less than diastolic. So you saw normal is S should be more than D. So if there is a mild hepatic impairment, systolic becomes smaller than diastolic. And in the Doppler images, it looks like this. So systolic becomes, so ideally this should be more and diastolic should be smaller. Here you see systolic becoming smaller than the diastolic. And so the reason for that is because there is a increase in the congestion and there is an back effect from the RV that is getting reflected on the vein. And that's how you would see the systolic being smaller than the diastolic. And if there is severe hepatic impairment, then the S wave gets reversed. So you will have an S wave going above and then you have a D wave like this. So in Doppler image, it looks something like this. So you'll have a zigzag. So it's like a sawtooth. You have a S above and D below. So typically you should have S bigger than D. In mild impairment, S becomes smaller than D. In severe hepatic, where there is severe hepatic congestion, you will have a peaking of the S system. S becomes positive. So this is called S wave reversal. And then this, and all these waveforms can be severely limited when there is a severe tricuspid regurgitation. So when there is a severe tricuspid regurgitation, so interpreting these waveforms can be difficult and it may be sort of confounded by severe TR. So that is something one needs to keep in mind. So that is about the hepatic vein assessment. So now looking at how do we go about assessing portal vein. So now we have assessed hepatic vein. For portal vein, see for all the trainees who are listening to this is important. Position of the patient and positioning of the probes are extremely important. So please lie the patient flat and bend the patient at the knee joint and flexion at the hip. And if they're conscious, you can ask them to deep breath. That will open up the veins because finding portal vein may not be as easy as hepatic vein. Hepatic vein is fairly easy. Once patient takes deep breath with a hip flexion, the hepatic veins tends to open up like that bunny sign. But portal vein not necessarily can be always that easy as hepatic vein. So the position of the probe is in the anterior axillary line. It has to be in the anterior axillary line for the portal vein. So preferably you would place it in the anterior axillary line on the right side, right hypochondrium. So it is the right upper quadrant of the abdomen in the anterior axillary line is where you should keep the probe. So this is just a diagrammatic depiction as to where you would want to keep. So it has to be in the right upper quadrant in the anterior axillary line for the portal vein. And portal vein looks like this. So you'll see once you put a Doppler, you will see a red sort of a flow towards the probe, and this is the portal vein. So this is how typically it is seen. And when you put a Doppler, when you put a cursor on this red sort of a flow that is flowing towards the probe, so you would see a monophasic. You will see basically a very fuzzy sort of a flow like this once you put a Doppler. This is normal. So basically, portal vein should not have any pulsatility. It is a monophasic, non-pulsatile flow. And you will see like this in like a very fuzzy sort of a picture. So basically, it will be like this. So this is a schematic representation where we look at pulsatility index, where we look at Vmax minus V minimum. So here you have to see there will be a small pulsatility. We have to calculate pulsatility index by looking at Vmax minus V minimum divided by Vmax. So the normal is less than 30%, which means there should not be any pulsatility. It will be flat, almost flat like this. Okay. So if you look at closer picture of the Doppler, they look like this. So you look at the Doppler maximum velocity divided by minimum velocity. Maximum minus minimum divided by maximum velocity will give you pulsatility index, and that should be less than 30%. And basically, the way you can remember is it should be a linear flow. There should not be much pulsatility. That is normal portal vein. So if there is a mild portal vein abnormality, then you will see the pulsatility. So you will see a waveform which will sort of emerge. So the pulsatility index then will remain 30 to 49%, which is again, you look at the maximum minus minimum velocity divided by maximum, and you look at pulsatility index, that should be 30 to 49% is mild portal vein. And if you look at the Doppler image, a waveform starts appearing, which indicates to you that there is pulsatility that is started. There is more congestion. That's why you are seeing more pulsatility. There's more turbulence, and which means there is portal pressure building up. So that's mild portal vein. If it is severe portal vein abnormality, pulsatility index is more than 50% because you see a huge waveforms. So the pulsatility index will be like this. So you can appreciate the difference. So if it is a normal portal vein, it will be a linear sort of a flow without any pulse. Mild means there will be some pulsatility index, 30 to 49%. If you see huge waveforms, then the portal pressures have really gone up and there is more venous congestion. So you will see something like this. So this is about portal vein. So the first step in VExUS is you look at the IVC more than 2 centimeters. Then you know that you have to move towards looking at the hepatic vein. And we looked at the hepatic vein in the same area as where you would see the IVC. And you look at the S and D ratio. Okay, so S should be more than D as a normal, S less than D mild, and S reversal is severe. In portal vein, it has to be a linear flow without pulsatility. If you see pulsatility, it means there is increase in the portal pressure. And for this, the probe has to be kept in the anterior axillary line in the right upper quadrant. So positions are important because not easily you will get a portal vein. So once you position the patient properly, once you keep the probe properly and possibly tell the patient to take a deep breath, these veins open up very well. So this is about the portal vein. And see, this is again thanks to I think Fishkesh has sent me this. So you see a nice pulsatility index here. So you see big pulsatility, which means the portal pressures are high. So this is a severe portal vein impairment. So now looking at the intra-renal. So friends, I have to say intra-renal veins are very difficult to visualize. You should have a good sort of a Doppler probe to identify renal veins and get the waveforms, because we have tried it, because if the balls are distended, and so there are a lot of reasons that renal veins may be very difficult to get the Doppler on, especially a good Doppler flow. So Rishikesh always sends me the fantastic images on intra-renal veins. For the renal veins, again, patient has to be in a supine position and the probe has to be kept in the posterior axillary line. So Anterior axillary line would be for the portal vein. Posterior axillary line would be for the intrarenal veins. And you will see a fuzzy picture like this. So it is not the main pulmonary vein you keep the probe on. The probe, the ultrasound probe or the insinuation has to happen for the interlobar veins, because that is where the pressure reflections happen. And both arterial phase and the venous phase will be seen like this. So it is the interlobar veins where you see here is where you have to place the sample and the Doppler cursor and then do your waveform assessment. So if there is a normal intrarenal venous flow, so you'll have a systolic and the arterial and the venous phase. It will be a continuous monophasic flow like this. So this is a normal intrarenal venous flow. So when you put an actual Doppler wave, it looks like this. So you will have a monophasic. You see here, there is no huge sort of a fluctuation. So arterial, this is the arterial phase, this is a venous phase, and it's a monophasic flow. And if it's a mild intrarenal impairment, basically you'll see a systolic phase and a diastolic phase. It becomes a biphasic flow. So a biphasic flow with a systole and diastole. You'll see two sort of a blobs below. So in the actual waveform, you look like this. So this is an arterial phase. There is a systolic and diastolic phase. This is the mild intrarenal vein abnormality. In severe renal vein abnormality, you'll see only diastole. If there is severe intrarenal vein, then the monophasic flow will be there, but there will be only one diastolic. So normal is there will be a monophasic without systolic and diastolic. Mild, you'll have systolic and you'll have two blobs like this. And if it is a severe impairment, you'll see only diastolic phase. Okay? So this is how you see. And in the echo, you would, or in the ultrasound waveform, you would look like this. So this is the D wave that you would see, only diastolic. So this is severe intrarenal impairment. So I'll show you the video which Hrishikesh has sent me. So these are beautiful images he has sent. As you see, this is the hepatic vein. S wave is bigger than the D wave. And here you see the portal vein, which is not hugely pulsatile, which is monophasic. And this is the renal vein. You see there is a biphasic, systolic and diastolic, which are both seen down, which is a mild renal impairment. So I'll just play the video. I think he has sent me these Doppler images. So you would see, so this is the intrarenal vein, systolic and diastolic portal vein, where it is sort of mildly pulsatile. It is not hugely pulsatile. I would say mild portal impairment, mild renal impairment, but hepatic veins is normal. So S, because S is bigger than D. So those are the images. So now coming to VExUS grading. So those are the three important things for all the trainees to remember. So first you start off with IVC, less than 2 centimeters, you cannot proceed to do VExUS. If it is more than 2 centimeters, you go on to look at hepatic vein by placing the probe few centimeters lateral to the Ziphi sternum, asking the patient to take deep breath with the hip flexion. So you will see a bunny sign. You will see a left hepatic vein, middle hepatic vein, and the right hepatic. You can place the probe in any one of them and look at the waveforms. S should be larger than D, S smaller than D, mild hepatic impairment, and S reversal, severe hepatic. Then you go to anterior axillary line in the right upper quadrant to look at the portal vein. Portal vein, they should not be pulsatile, which is normal. If there is a huge pulsatility, it's severe portal vein. Then you go to posterior axillary line towards the kidney to look at the intrarenal veins. You place the probe and you look at the, it will be a monophasic flow if it is a normal intrarenal pressure. If a mild impairment, you will see systolic and diastolic. You will see only diastolic if there is severe renal condition. So that's all about VExUS. So it's not a rocket science, but it is good to keep doing it to understand. So VExUS grading is only summary of whatever I've said. If it is less than 2 centimeters, no congestion. If it is more than 2 centimeters, then you have to look at abnormal wave. So if there are no abnormal waves, then it is mild congestion. If there is any of those, what I mentioned, hepatic, portal, or renal, any one abnormal wave is present, it is moderate. So if you find abnormal wave in the hepatic vein, then you know there is a moderate congestion. If you see S reversal, you don't need to go to portal vein, but for academic reasons, you can look at portal vein to look if there is pulsatility. And if there are two abnormal veins, like you have one abnormal vein hepatic, and then intrarenally, you will see systolic and diastolic, like what Hrishikesh has sent. There are abnormalities in two waveforms, but the hepatic vein was normal in what Hrishikesh has sent. But you saw portal vein had pulsatility and renal vein had SND, then it means severe congestion. So the best sort of patients where you can do this is in all heart failure patients. So go to your cardiology patients who are getting treatment for heart failure. That is where you can pick up the best images for doing this Doppler to look at the congestion, because these are typically the patients where there will be congestions and you can possibly get these waveforms to look at. So that's the whole thing. So there is this study from this Canadian proponents, Bubin et al., which has come in 2020, where they have validated these sort of a changes, and they found that there was a very good correlation with acute kidney injury when there was this VExUS score that was present, which was more than 1 or 2 and so on and so forth. So this is all at this point of time about VExUS. So the acronym of VExUS is venous excess of ultrasound, and that is in summary or brief of overview about the whole VExUS. So thank you one and all. So I end with this. So you can visit my website www.drpradeeprangappa. So go to these exam lectures. Most of the lectures are categorized into various subjects, and ultrasound echo we have a separate section. So it becomes a little more easier than YouTube for you to look into these subject-wise, especially during your exams. And end with this beautiful quote: "It's a capital mistake to theorize before you have all the evidence." Biases statement. So VExUS is not a theory. So it is a practical application. I had a chat with Rishikesh. He said there is now looking at even the mesenteric veins. So now the science is moving forward to looking into the mesenteric vein Doppler. So it will be exciting to see more work happening in this area to look at the gut congestion and so on and so forth. So thank you one and all.